Okay, well, let's get started. So again, I thank you all for joining me today. The topic is laser therapy for ankle sprains. A bit of housekeeping before we get started. As usual, the webinar is always recorded so that if you leave early and you need to catch it later, or if you want to review it, it takes us about a week or so to edit it, and then we usually send out an email with a link to watch it again on YouTube. And eventually it's shared on our password protected platform for BioFlex practitioners as well. Now, the topic today, as I mentioned, is ankle sprains, a fairly common injury that comes into our offices, especially now that the weather's getting a little bit nicer and COVID is slowly getting under control. You'll start to see more and more of these patients coming in with ankle sprains. So I thought it would be a good topic to discuss. So I'm going to review the etiology, the epidemiology of ankle sprains, a bit about the pathophysiology, the Ottawa ankle rules, which you may or may not be familiar with depending on what kind of practitioner you are. But I think it's important that if you are a practitioner that can refer out for x-rays or even any clinician that is questionable about whether or not x-rays should be recommended, the Ottawa rules is a standard evidence-based standard that we now use. I'll talk a bit about treatment, not just laser treatment, but other types of treatment for ankle sprains, the prognosis, and then specifically a couple of research papers, as well as the BioFlex protocols that would be applicable for treating ankle sprains as well, and we'll have time for Q&A. So I'm assuming everyone can hear me okay. And please ask your questions, type them in. I will address them at the very end. So if you have any questions, just type them in and I'll definitely get to them at the very end of the webinar. So most ankle sprains, as you probably are aware of, they involve the lateral complex of the ankle, specifically the anterior talofibular ligament and or the calcaneofibular ligament located attached to the lateral malleolus, to the calcaneus, and of course to the talus as well. So ankle sprains vary depending on the mechanism of injury, whether it's a high energy kind of situation like a fall from a height or what have you, or low energy. The position of the foot obviously plays a critical role as to what structures might be injured, and if there's any rotational forces as well. So these all play a role as to what structures possibly might be affected when a person has an ankle sprain. So as a review, many of you are aware that when we're talking about a sprain, we're talking about a ligamentous injury. And of course, there's three grades, grade 1, 2, and 3. Essentially, grade 1 is a mild stretching, maybe some small tears in it. So not too bad, really. A grade 2 would be a larger tear, but still intact ligament. Whereas a high grade 3 sprain, especially in the ankle, you're looking at a complete rupture of the ligament, which then can compromise the integrity of the joint itself. So that's not an uncommon injury, by the way. You'll see this happening even in ankles that maybe never had a sprain before, and you can actually completely tear the anterior talofib ligament especially right through. So it's important to recognize that as well. So the mechanism of injury also plays a role as to whether or not you're going to look at other structures like tendons. Tendons can often be injured with ankle sprains as well as fractures. And I'm going to review the Ottawa rules for when you might decide to x-ray, because fractures are a fairly common sequela of ankle sprains as well. Generally speaking, the research shows that between the ages of 10 to 19 is associated with the highest rates of ankle sprain. On average, 7.2 per 1,000 people of that age bracket will have an ankle sprain. So that's actually really high, a high rate. So this will come across to your clinic, and certainly if you're working with sports teams, that is a very common scenario. So males between 15 and 24 also have higher rates of ankle sprain than their female counterparts, whereas as the age gets a little bit older into over 30, then we actually start to see more of a rate of higher females to male ratio. And as I mentioned, is very common in athletic activities. So about 50% of all ankle sprains reported occur because of some type of athletic or sporting event. So the joint, review of the anatomy and a bit of the pathophysiology. The joint, as we know, is stabilized by three types of ligamentous systems. On the lateral aspect, we have the lateral ligament complex consisting of three ligaments. Then we have the medial deltoid ligament system, much stronger, and the syndesmotic ligaments in between the tibia and the fibula. And those are called syndesmotic ligaments. You can see a little picture of that on the right-hand side here. Sometimes referred to as interosseous membranes. So the three ligaments that compose the lateral complex, I mentioned already, are two of them, the anterior talofib and the calcaneofibular ligament, as well as the posterior talofib ligament. So the most common injury that occurs in the lateral complex is by far and away the anterior talofibular ligament. So you should be familiar with where to palpate that, because generally speaking, if you know where that is and you push in on it, it's pretty easy diagnosis to make as long as you're palpating the right structure. So it is the weakest ligament of the lateral complex, which obviously makes sense that that's the one that's going to be injured more frequently. So approximately 70% of all lateral ankle sprains involve the anterior talofibular ligament. And usually this is due to plantar flexion combined with inversion. So that classical going over on the inside of your foot and going into plantar flexion. Whereas the calcaneofibular ligament is more commonly injured in dorsiflexion and inversion mechanism. So, you know, you can always ask your patient, and you should be asking your patient the mechanism, what happened, what sport they were playing, kind of visualize the possible mechanism and then the structures that might be injured as well. The posterior talofib ligament is the least commonly injured with respect to the lateral ligament complex. So it's hard to see, but it's right in the behind that, obviously behind the fibula. The medial deltoid ligament is the strongest of the ankle ligaments, and it tends to be injured obviously with eversion injuries. The isolated deltoid ligament injuries are actually fairly rare. So just to have a deltoid ligament sprain, you usually don't see that because it tends to, this complex tends to limit talar abduction movement. So you tend to see forceful injuries of eversion, and you'll see fractures usually associated with this as well, but not always. So it's usually not as common and can be more serious when you're dealing with a medial ankle sprain. Now, syndesmotic injuries, these are really interesting because they're oftentimes referred to as high ankle sprains. They're interesting because it's not a traditional ankle sprain. The injury is a little bit higher up, and they tend to be a little bit less common, as I mentioned. You'll see them in competitive sports like and professional sports or high amateur sports like football, skiing, hockey, and rugby specifically. It involves the membrane of the ligaments in between the fibula and the tibia. You can sort of see a bit of the red outline of those ligaments on the right. So the most common mechanism of a high ankle injury is external rotation and or dorsiflexion. When I was preparing for this webinar, I was doing a bit of reading, and they talk about National Football League players having a fairly high incidence of high ankle sprains. And it definitely takes longer to repair and to overcome than a regular standard ankle sprain. So it's important to recognize that that if the patient does have a high ankle sprain, that you give them a good prognosis, because last thing you want is to say they're going to be ready in a couple of weeks when that might not be the case. Now, the Ottawa ankle rules was developed by a Canadian physician, Dr. Ian Steele, and he basically demonstrated a predictability scale such that with certain palpation and pain location would then require a set of x-rays to rule out fractures. And this was in adults and children over the ages of 5. So it's a great set of rules so that we don't just x-ray every patient with a sprained ankle unless you really feel that there's a need for that because of a possible fracture. So as far as taking ankle x-rays, there's a few rules here. Essentially, if there's pain in the malleolar region and any of the following, then it's suggested that ankle x-rays are taken, including tenderness over the posterior edge of the distal 6 centimeters or tip of the lateral malleolus, tenderness over the posterior edge of the distal 6 centimeters or tip of the medial malleolus, and inability to bear weight immediately after injury and for 4 steps at the time of evaluation. The rules go on to talk about also x-raying the foot. If there's pain in the midfoot zone and bone tenderness at the base of the 5th metatarsal to rule out a fracture there, or bone tenderness at the navicular, or the inability to bear weight immediately in an emergency department for 4 steps. So these are the generalized rules that have been developed and are well established now, not just in Canada, but worldwide. So if you look at these rules, you can see under A, you're looking at the palpating the medial fibula and the distal end or the lateral malleolus on the posterior edge. So if there's palpation on the bone, pain with palpation on the bone there, then that's indicative of getting a set of x-rays. Whereas on the medial flip side, same thing, the distal 6 centimeters of the fibula, or sorry, of the tibia, the medial malleolus, that would be the medial malleolus. And again, you're looking for bone pain upon palpation. And then you can also see the base of the 5th metatarsal, as well as the navicular bone. You should be aware of where to palpate those particular structures and if there's any pain in those areas as well, which would lead you to sending the patient to emerge for an x-ray. Initial treatment, really, we all are aware of this. RICE, or actually PRICE now as it's known, P being protect from further damage. So let's say on a basketball court, I used to play a lot of basketball. What you want to do is you want to tighten up the laces of your preferably high top basketball shoe to protect it. You can use a splint or whatever you have just to ensure that no further injury occurs. And of course, rest, ice, compression, elevation. I don't need to explain all that. But of course, being laser therapy here, it's a good idea to add that. Within 24 hours, you can start to treat with laser therapy. And I'm going to suggest using an anti-inflammatory protocol initially in the acute phases, and I'll talk a bit about that towards the end of the webinar. So resting of the injured ankle, obviously for the first few days is highly recommended. And then the patient can gradually resume their activity depending on how they can tolerate that. They may need crutches for a few days or what have you, just for needed comfort and to take off pressure off the area. You can immobilize the area if need be with a walking boot or an air cast, that kind of thing. And generally speaking, they have found a correlation that if there is immobilization early on, along with early weight bearing with support. So example, you're trying to walk around with it being supported. This has been found to improve the return to sports, return to work, and persistent swelling and range of motion and patient satisfaction. As far as rehab goes, the early rehab should focus on restoring the range of motion, then proprioception techniques and neuromuscular training, and then eventually strength training as well, especially the perineal muscles. And this helps prevent recurrent injuries from occurring as well. And then the strengthening phase really should only begin when swelling and the pain has decreased substantially and the patient's now basically has full range of motion, both actively and passively. The functional braces should really only be used early on in the strengthening phases when the patient initially returns to activity. Prognosis-wise, mild to moderate ankle sprains usually have full recovery in a couple of weeks. So that's the time frame. If you're adding laser therapy, I've seen them recover in a week. So, it does really accelerate the healing time. The rule of thumb is before a patient returns to their sport or their activity, basically their symptoms should pretty much be resolved. So last thing you want to do is be sending out a patient that still has significant pain or mobility issues. And then for highly competitive athletes, well, then we're looking at maybe making sure that that these issues don't become chronic. You want to make sure that to avoid recurrent injuries and ankle instability. So you want to make sure that they're definitely attended to with respect to that as well. Now, recurrent instability and other issues can be seen up to over a third of patients, and these complications can include chronic pain. I've seen a lot of patients that have had ongoing ankle pain secondary to ankle sprains, and it's a real problem. There can be recurrent ankle instability, especially if there's significant tear in the ligaments. There can be osteochondral defects in the talus. There can be peroneal tendon injuries. I mentioned about the tendon aspects, so make sure you look at the tendons as well, and even damage to neurovascular bundles as well. And that long term, it can lead to arthritis as well. So these are all complications that you want to avoid by early treatment, and early treatment that involves improving the healing as much as possible to normal. Research-wise, there's a couple of papers. Now, it's not a lot on ankle sprains specifically. This one is the most recent one. They did a really interesting technique. They called it fractionated irradiation of photobiomodulation in ankle sprains. This was by the American Journal of Physical Medical Rehab. They looked at 19 patients. They were randomly assigned. One group received photobiomodulation therapy in this what's called fractionated irradiation. I'll explain that in a sec, along with rest ice compression elevation, and then a sham group, then a group that received only standard treatment without the laser. They use red only, which is interesting, but you can still do it because these structures aren't that deep, although you won't get much lead into the joint. You can see the amount of energy. Now, they called it fractionated because what they did was they did 2 sessions 30 minutes apart. The first one used 4.5 joules and the second one used 9 joules per centimeter squared. I'm not really sure I understand the reasoning behind that, but it ended up being successful. So who am I to judge that, right? They used the foot and ankle disability index and a VAS as well at onset, 10 days and 6 weeks post-treatment. If you look at the results, when you're looking at the functional disability index, you can see group 1 that had the laser compared to group 2. The functional index increased statistically to a greater degree than without laser therapy, as well as the VAS baseline, and you can see over 10 days and 6 weeks that there was less pain at 6 weeks and 10 days compared to the control. So obviously they concluded that this novel fractionated irradiation or photobiomodulation combined with RICE was more effective at improving function and reducing pain than just standard rest ice compression elevation. Another paper that's well documented and oftentimes referred to was published in 2004, and this one looked at the effects of photobiomodulation to reduce swelling or edema in second-degree ankle sprains. So they looked at soccer players specifically with these second-degree ankle sprains, and they're randomized into 3 specific groups, group A, B, and C. They either received just RICE or RICE with placebo laser or RICE with a near-infrared 820 nanometers laser with 40 milliwatts, and they pulsed it at 16 hertz, which is interesting. And they measured the volume of edema at 24 hours, 48 hours, and 72 hours later. So this gives you a good indication if this edema or swelling is being accelerated as far as its reduction using laser therapy. When you look at the results, it was pretty clear that you can see the orange is the rice, the red is the rice and placebo, and the blue is the rice and the laser. And you can see the change in volume in milliliters after 24, 48, and 72 hours. So obviously, the greater the volume of change, meaning that less swelling was occurring. So there is significantly less edema, especially after 48 and 72 hours compared to a control or control plus placebo. So obviously they concluded that laser therapy combined with the rice can reduce edema much sooner than standard treatment alone. Okay, now as far as protocols go, if a patient presents with an acute injury, it's always good to go with an inflammatory protocol, or shall I say anti-inflammatory protocol. It's used for inflammatory conditions, but the goal here is to reduce inflammation as much as possible. The main difference here is that we're using a slightly longer duration of treatment. So the red is set at continuous wave. So I'm talking about the large surface array, not the laser probe. And you can see here it's set at continuous wave for 8 minutes. Whereas the second step would then be the near infrared light, and that's set at modulated at 10 hertz and 30% duty cycle. So a relatively low dosage of infrared, a much higher dosage of red light, and again for 8 minutes. So this is a standardized inflammatory protocol. You can use this in the first few days to get things under control. Then I would recommend going into the foot and ankle protocol. Start with stage 1. The differences here is the time is a little bit less, 6 minutes. Now I will talk about altering the time a little bit depending on where you're treating. So 6 minutes of continuous wave red, and then the second step would be 6 minutes of the infrared dual array, set at a little bit higher frequency compared to the inflammatory protocol at 50 hertz, and a much higher duty cycle, which will give you a lot more energy at 60%. So as far as where to place the arrays, usually we recommend, regardless if it's a medial or lateral ankle sprain, we do usually recommend a minimum of 2 and if not 3 placements. On the standardized lateral ankle sprain, the one that's most common, you're going to place it over the lateral malleolus and ensure that it covers the anterior talofibular ligament and or the calcaneofibular ligament as well. You can increase the time from the standardized 6 minutes and customize it to 8 minutes red and 8 minutes infrared as well. Just give that area that's most affected a little bit more dosaging. Make sure that when you apply the array, obviously the area is going to be sensitive, so don't strap it on tightly. Make sure it's comfortable, or preferably you can even just gently place it over the ankle and maybe not strap it into position, or use a pillow or a very gentle low weight to keep it in position as well. On the medial side, I do recommend a medial placement, even if it's just a lateral ankle sprain. Again, it's going to help with overall edema in the joint as well. So again, cover the anteromedial aspect of the joint. If in fact it's a deltoid ligament sprain, then I'm going to suggest similarly to if it's a lateral ankle sprain, increase the time to 8 minutes red, 8 minutes infrared as well. And again, be careful of the malleolus because that can sometimes be tender. So just be gentle with that area when you're treating. Now, a high ankle sprain, which kind of makes sense, you're going to take the array a little bit higher up to wrap around the posterior aspect of the distal area of the fibula, where it attaches to the tibia, and then wrap that around all the way to the front, so it also capturing the anterior distal tib fib syndesmotic joint. I do recommend increasing the time to 8 minutes red and 8 minutes infrared in this area as well. Along with that, I recommend another placement covering the talocrural joint. So the standardized placement just kind of shifted down a little bit So you're overlying the dorsal aspect of the foot because you'll get a lot of swelling in there as well. So it never hurts to treat that area. In this case, you just use a standardized 6 minutes of red and 6 minutes of infrared as well. It's not uncommon that we do another placement for ankle sprains, regardless of the type of ankle sprain, and this will be done on the plantar aspect of the foot. It's an optional placement, but I think it is very helpful. In this case, you're going to apply it on the plantar aspect, overlying the subtalar and the mid-tarsal joint. So gently wrap it around there with your strap. You should be able to get a nice position. And this can reduce inflammation and edema on the inferior aspect of the ankle joint complex. As far as laser probes go, for the infrared laser probe, for the most part, we're treating relatively superficial ligaments, so you don't need a huge amount of joules per point. I'm going to recommend maybe 1 or 2 joules per point to promote photobiomodulation. Treatment into the joint, so when you're trying to get light deeper, you can pretty much double that, so 3 to 4 joules per point allows that light to penetrate a little bit deeper into the joint itself. So if you're using the laser probe at 100% power, 1 to 2 joints is in between 6 to 10 seconds or thereabouts per point, and then moving it to the next spot, whereas 3 to 4 joules involves anywhere from 15, 16, 17 seconds, all the way up to 20, 21 seconds, 22 seconds to get you that 3 joules to 4 joules per point. And that's, remember, this is allowing the energy to get a little bit deeper into the joint itself to try and treat the inflammation that's deeper set. Now, you can try to achieve analgesia as well. And I talked a bit about this in the advanced class that we had over the weekend. Essentially, when you look at the standardized dose response curve, we used to call it a biphasic dose curve, but now it's considered multiphasic because they're now understanding that you can inhibit with light energy, and the inhibition actually inhibits the analgesic pain fibers, the nociceptor fibers, anywhere between 10 and 20, 30 joules per centimeter squared. Any more than that, you start to get heat production, and that can cause damage. So if you want to create analgesia, you need a much higher dosage than the 2 to 5 joules per centimeter squared you'd associate with the photobiomodulation. And this can be achieved relatively easily, provided that you have enough energy and the surface area of that energy coming out of a laser probe. Remember, this is going to be done with a laser in order to achieve that. Because it's superficial and a lot of the nociceptors are superficial, I'm going to recommend using a red laser probe for that. And so to achieve 10 joules per centimeter squared, so if I backtrack, you can see 10 joules is right at this inhibition point. Then at 100% power, using the red laser probe, you're looking at around 13 to 14 seconds per point, and you can go up into 15 joules per centimeter squared, and that gives you about 20 seconds. So I would say anywhere from 15 to 20 to 30 seconds per point over the painful areas of the ankle sprain will provide some analgesic effect as well. Okay, so that's the end of the lecture. I will take some questions now. Just a reminder, I am doing a basic certification training on March the 20th on the Saturday. If you haven't signed up or you'd like to get certified, just go to our website and you can register for that. The next one after that is on Friday, April the 16th as well. All these dates are on our website, bioflexlaser.com. We did have a very successful advanced certification training over the weekend for lumbosacral conditions. Dr. Van Ewan and Slava and myself did some presentations. It was really well received. The next advanced training is in September on cervical spine conditions and December the 4th on cosmetic applications of photobiomodulation. And before all that is the June 5th, we have a master class with a keynote speaker, Dr. Ashley Banjan, a neurologist from Durban, South Africa, getting tremendous results, treating all sorts of neurological conditions, everything from nerve-related conditions in the lumbar spine and neck, peripheral, issues, and of course to neurodegenerative disorders as well. We'll be putting all the details on our website in the next week or so, so I encourage you all to check that out. It's a full day event. It will be really fascinating. I guarantee you will be blown away with Dr. Bonjohn's work. So if you have a chance to listen, that's great. If, by the way, you can't make it because of other obligations, then it's recorded and you can actually watch it on another date. And that goes for all our advanced trainings. If you're not able to tune in that specific day, you can actually watch a recorded version of it and take the certification training test as well. So hopefully you guys can do that as well. So I'm going to look at some questions right now. I'm just going to pull those up and see what we have here. Okay, let's see now. So I have a question here. Does it work well with Achilles tendon injuries? And definitely different protocols, different way of approaching it. And I've done a webinar on that, but it's been a while, so I may revisit that. But it's definitely very effective on Achilles tendinopathies. I do have a question from Carlos. Oh, he's just having a difficulty, never mind, on listening in. Well, hopefully he can tune in later. I have a question from Jill. Hi, Jill. With a small grade 2 tear in the lateral Achilles tendon, 5 weeks old, I'm using the lower extremity protocol stage 1, started first treatment yesterday. You know what, Jill? I'm going to respond via email because there's a lot of information there. Can you just email me directly on that, and I will definitely address that. It's just that there's a lot to look at there, and it's very specific to your patient, so I'll definitely address that. A question from Maria. Hi, Maria. What would the protocol be for a navicular fracture resulting from an ankle sprain? So, you know, you're going to use a similar protocol. You want to make sure that the navicular bone is covered with the array. But when it comes to using a laser probe, that would be the bit of a difference, because for the fracture, you want to try and get light into the bone as much as possible. So I would use much higher amounts of or more joules per point or higher energy densities. So I'd be holding it for 20, 30, 40 seconds over the navicular bone to get light into the actual bone itself. That would be the key difference. And you would want to treat the navicular both from the dorsal aspect and the plantar aspect as well. A question from Sophia. What is the best position for the ankle to do the placements? The pictures show the ankles at 90. Is it better to have the patient stretch it out when treating the lateral side? Like as far as ankle position goes, there's a few considerations. One is how comfortable it is for the patient. In an acute setting, it may be challenging to move the ankle around very much, but as things progress, then you may want to approximate. It depends, right? You can approximate the ligament by everting the ankle complex. If you want to open the joint, then you can open the joint to an open pack position as much as possible when you're doing the laser probe as well. So you can alter the positions, but when it comes to using the array, number one is make sure the patient is comfortable, and that if you're able to open it up a little bit during treatment, then you can do that as well too. A question from Kathy. How can you do the first step of the anti-inflammatory protocol with the home BioFlex system? Since all the programs are programmed. That's the whole thing. This webinar is geared towards the professional systems. That anti-inflammatory protocol is not embedded in the home system. Kathy, if you want to email me, I can take a look at the protocols that are embedded and see what's the closest, or give you some recommendations on that. I don't mind doing that. Just remember, folks, my email is david@bioflexlaser.com.